Dr. Macharia Waruingi, and I'm very excited this afternoon. I am excited because I'm recording this video using Camtasia directly from my computer. And I want to record a presentation about maximizing particularizability. It is a strategy for emerging knowledge for the design of systems for personalized health. And this is a speech that I gave at the Mayo Clinic Center for Innovation during the 2010 Transform Symposium in Rochester, Minnesota, United States. Okay, so I spoke about maximizing particularizability as the foundation of transformation of health services in the United States. And maximizing particularizability is a concept that I stumbled upon when doing research in global health. Particularizability, I consider it the opposite of generalizability of knowledge product. That is the hallmark of scientific inquiry. Personalized health is the disruptive change that has happened in the marketplace following the information technology revolution and advances in human genetics. Personalized health has shifted the focus from the institution to the individual and from the population to the individual. This disruptive change calls for customization of health promoting services. And traditionally, we have focused on generating knowledge to help us know how to help the sick people better. But according to Peter Miller, personalized healthcare market will focus on keeping healthy people healthy. The focus on the well rather than the sick is a radical departure from the tradition that requires radically different approach to strategies for generating knowledge. That's me, as you can see, that person flying there, making the great leap from my mansion in the village right here, down to your mansion in Rochester, Minnesota. And why did I do that? I did that because I wanted to understand global health. As a matter of fact, many people are dying because of diseases, the very diseases we're trying to eradicate. Efforts to eradicate malaria, for example, are followed by a wild upswing of severe form of drug-resistant malaria, and efforts to eradicate tuberculosis are followed by severe form of multi-drug resistant mycobacteria. Our solutions are prescriptive. We prescribe bed nets for villagers, and what's wrong with that? People in the village do not have a bed. Again, also, mosquitoes do not wait for you to go to bed so that they can come and bite. How do we miss such basic facts? We miss such facts precisely because our strategy of knowing does not help us know what is going on in the village. Our solution to provide bed nets seems generally relevant. The solution fails, however, in particular situations. The solution is particularly irrelevant. Generally, good solutions do not work in particular situations. If we try to fit them, we fail, much like the fixes that fail system archetype in systems thinking. Our solutions seem so relevant, yet they fail, a true relevance paradox. Why do we fail? We fail because of the way we look at individuals. Each individual has a depth that is not discernible by looking at that individual from outside. In fact, you have a depth that you cannot explain, yet knowing that depth is critical to serving your needs. Michael Polanyi in 1956 said, "We can know more than we can tell. We can only avoid the relevance paradox by knowing the more that each individual can know but cannot tell." Emergencing is a discipline of how to know the more that others can know but cannot tell. Alison Wiley in 2002 helped us to distinguish two modes of explanations. On one hand are those explanations that cover the greatest numbers of individual cases. On the other hand are the particulars of every given case. The scientific production is concerned with explanations that cover the greatest numbers of cases. Such methods seek generalizability of observations. Such explanations are nomothetic. They are nomological. We are focused on standardization. We believe that the mean and the standard deviation describe everything about a given population. When we report the mean and the standard deviation for incidence, prevalence, mortality rate of a given condition, we say that we have described everything about that condition in a population. It turns out, by reporting the mean and the standard deviation, we are reporting only the events which are at the tip of the iceberg. We emphasize on what we can count and measure. But according to Albert Einstein, not everything that counts can be counted. Peter Senge in 1990 gave us the metaphor of the iceberg to explain how we can see things that count but cannot be counted in a human system. Remember, only a small portion of the iceberg is above water. It is impossible to judge the shape of the portion beneath the surface by looking at the shape of the portion above the surface. Just like an iceberg, what is going on in our community is hidden from view. What we see as incidence, prevalence, death rate, what we describe with the mean and standard deviation is only the tip of the iceberg. The scientific production does not help us to see beneath the tip of the iceberg. And in order to see beneath the tip, we need a different kind of strategy in the way we look. According to Senge, human systems are stratified in multiple levels: the events level, the patterns level, the structure, the mental models, and the container. The events are markers in time where multiple variables are observed. For example, the incidence, the prevalence, and the death rates mark events. Patterns are changes in variables that occur over time. We can see patterns like disease patterns, consumer trends, and projections, and such things. The structure answers the question, what is causing the pattern that we are observing? The structure is composed of cause and effect relationship. Beneath the structure are the mental models that keep the structure doing what it does. According to Senge, the elements of the mental model are attitudes, beliefs, morals, ethics, expectations, values, and experiences. Holding everything together is a container or the framework of thought that shapes and constrains our mental models. In the traditional role of marketing of healthcare services, we place emphasis on marketing healthcare facility to the consumer. We persuade the potential patients to think of physicians and hospitals. We center our marketing efforts on distinguishing one hospital from another, one group of physicians from another. Manufacturing companies work with hospitals to identify the market demand for their products. The hospital is a place where the product is offered to the consumer. Right here. We never, ever, ever, ever invite the consumer to these negotiations. So the negotiations are just taking place between the industry and the healthcare system. The relationship between the healthcare system and the consumer is much akin to the relationship between the global health providers and the villagers. However, this structure is rapidly changing and the consumer is going directly to the industry, effectively bypassing the healthcare system. What we do, we are being bypassed. As healthcare leaders, we must place emphasis on dealing better with well people. It's about wellness, not just patients, well people. Services for keeping people well will rely on understanding particulars of every individual. Services for helping well people better will be customized to specific needs of specific individuals. Human needs are tacit and are driven by mental models and the container of the mental models. We have to find a strategy of knowing attitudes, beliefs, morals, ethics, driving each individual. The problem is that mental models are tacit. According to Erickson, 1956, the tacit dimension is knowable by subliminal perception or subception. How do we know by subception? Luckily, we don't have to invent this because Kitaro Nishida in 1921 explained that human beings can know by subception in a space for knowledge emergence, which he referred to as Ba. Ba is a space of absolute nothingness. Kono, Nonaka Kono Entoyama, in 2001, distinguished four subdivisions of Ba: the originating Ba, the dialoguing Ba, the exercising Ba, and the systematizing Ba. In the originating Ba is where we observe phenomena. The consumer resides there. That's where the consumer exposes the attitude, beliefs, practices, morals, ethics, mental models. The dialoguing Ba, let's say an example, is when the consumer enters the healthcare system as a patient and establishes a dialogue, maybe with a physician who is taking history, documenting the clinical semiology, conducts a physical examination, and in combination with the exercising Ba, creates a clinical impression, gets a differential diagnosis, and creates treatment strategies for that patient. As you can see, the dialoguing Ba and the exercising Ba for this kind of scenario are kind of closely interrelated. The knowledge that is gathered from many patients is then systematized either in clinical research or clinical trials or administrative research, and it is published in journals and consensus statements for developing new strategies for treatment. Traditionally, the physicians or the healthcare workers would obtain the systematized knowledge from the systematizing Ba and interpret it for the consumer. But that was before the advent of the information superhighway. Now, the systematized medical knowledge from the systematizing Ba is flowing freely to the consumer in the originating Ba through the information superhighway, bypassing the providers and effectively disrupting the power structure in knowledge distribution. We are bypassed yet a second time. The problem is that we do not know how to go to the originating Ba. We have never been there. How do we go to the originating Ba? In order for us to be successful, we have to go down to the originating Ba, and we have to create intimacy, a very intimate relationship with the consumer and the healthcare system and the industry. The deep continual interaction is going to emerge in that kind of intimate relationship is a concept of indwelling. We have to stay there to observe phenomena. We cannot stand outside the consumer. We cannot stand outside the object of study. We have to enter into the object of study. We have to be intimately related to it. We have to adopt a very intimate scale of observation, a form of intimacy with the consumer that the discipline of the modern scientific method does not have. This is about participant observation. It's about adopting a very intimate scale of observation. We have to get very, very close to the observed. The knowledge that emerges from this observation will be an attempt to interpret or understand the phenomena that is going on. The forms of representation emerging from our intimate relationship with the consumer include phenomenology, ethnography, critical science, and grounded theory. It turns out you can reach different levels of understanding of representation with each product. For example, you can use phenomenology procedures to describe particulars of observed phenomena. I call this level 1 knowledge because it helps us to answer what questions about particulars of observed phenomena. Ethnography goes deeper. and requires long-term indwelling. Knowledge products of ethnography help to interpret the underlying processes. Grounded theory goes even deeper and helps us to understand underlying relationships that constitute the container of the mental models. I call this level 3 knowledge because it helps us to answer why questions, why people do things the way they do them. These strategies are about maximizing empirical adequacy. They're about gaining a deeper understanding of a particular individual or groups of individuals in a particular location. They're about particularizability. These strategies are not about generalizability. The scientific production is about maximizing generalizability. Emergencing is about maximizing particularizability. Can this be done in reality? Yeah. 7-Eleven Japan is the most profitable convenience store franchisor in Japan. The company has created an originating bar which comprises of hundreds of Bura Bura Shine, or what they call walking around employees who accumulate tacit knowledge about customer needs through socializing with customers in the store and outside the store. The company has also employed hundreds of field counselors who work to visit people in their homes to learn about what's going on in the community. The Bura Bura Shine and the field counselors advise the store managers on what is needed, what to order depending on what they learn from the community. 7-Eleven Japan has created profound intimacy with its customers. And because of this, 7-Eleven became very, very successful and acquired 7-Eleven, or acquired Southland Corporation, which owns 7-Eleven United States. Okay, can this be done in the United States? Yes. A good example is Interleukin Genetics, a company founded by a dentist. The initial focus of Interleukin Genetics was predicting inflammatory gum disease. It turned out that there was no clinical utility for that service. The company, which had raised money, collapsed and was acquired by, you guessed that right, Amway. You know that Amway has got a direct access to the consumer. Amway is a typical originating bar, and Amway has a very intimate relationship with the consumer to the extent that it is almost impossible to distinguish the consumer from Amway. Ladies and gentlemen, the power to transform healthcare services is at the source. We have to create capacity for originating bar, which is lacking in our health organizations. We have to use open inquiry design techniques for gathering knowledge in the originating bar. This process of emergencing will help to maximize particularizability. Thank you very much, ladies and gentlemen.